Okay. Um, so I'll come back to cachexia in a little bit. Um, for clinical manifestation, obviously, um, the clinical history is very important to determine, the nature of this person might have cancer or not. Things like irregular bleeding, like mammogram, um, exposures to certain radiation, that kind of thing. Mammogram to see if there's a lesion, uh, you know, um, skull-like lesion, or you can do a colonoscopy, see if there are polyps there, polyps in the colon. Is it normal cells or not? Normal cell. Um, Hyperchromatic, usually not very normal cell. And I was going to talk about how what we mean by the mass effect. Okay, and this is particularly when we're talking about tumor in the anterior pituitary gland. Okay, anterior pituitary glands secrete hormones, right? You know that, and we'll talk about the hormone that the anterior pituitary put out. In general, I just say it's flat peg, and that is, um, and we can talk about more about these hormones later. uh, uh, F is for FSH, LH, ACTH, thyroid stimulating hormone, prolactin, endorphin, and growth hormone. So the anterior pituitary put out these hormones. If they're small and they're functional, less than 1 centimeter, right? And they happen to put out a lot of ACTH, for example. A here is ACTH, okay? And ACTH will stimulate the anterior, um, sorry, will stimulate the adrenal cortex to put out things like aldosterone or cortisone. So when this thing is increased, then you get known as Cushing's disease, for example, right? If you don't know about this, we will talk about this more, but appreciate this is an idea. This is considered as a microadenoma. Okay, so if it's glandular, it's adenoma, right? So microadenoma means small, and they're usually considered as functional tumor. So in endocrine, we say, oh, if it's functional tumor, that means it's a tumor that produces the hormone. Okay. Now, if it's non-functional tumor, non-functional tumor are usually non-functional tumor do not put out the hormone. If they don't put out the hormones of, you don't know, right? If it's high ACTH, we see it and we say, oh, probably too much cortisone. People have Cushing disease, the face kind of like, like a person on steroid, the round face, buffalo hump, abdominal striation. We see that right away. But if it's not functional, the tumor will get bigger and bigger and bigger, and you don't know it, right? And oftentimes then, in the non-functional tumor, you will not discover them or you will not see them until they're like more than 1 centimeter. So they're considered as macroedema. In other words, macroadenoma. So in other words, they're going to be bigger tumor, right? So instead of micro, it is macroadenoma. And macroadenoma usually we'll consider as a mass effect. A mass effect. And so what they do is that while the tumor itself do not put out the hormone, but is actually taking up the space, so it's crowded out, for example, so that the other person do not put out ACTH, right? So ACTH might drop, or thyroid stimulating might drop, so the person might develop hypothyroidism, for example. So we call it this is the mass effect Or, in other words, most tumors are discovered because of local effect. They press on the nearby cells, for example, um, and prevent its normal function. Um, okay. All right, and neoplasm can produce this distant effect. That means throughout systemic, if you will, a person can develop cachexia, and cachexia is really people lost a lot of weight, and it's not just because it's just poor appetite, but in the case of cachexia, it is an active process that the cells are perhaps consume a lot, and we know that certain cancer cell can, import glucose much more than the normal cells. Um, uh, yeah, so usually late stage, someone have late stage cancer would develop cachexia. All right, any questions? Any other questions? Oh, here's cachexia. In this case, this guy has metastatic cancer. Um, and you see this, basically muscle mass is losing, cannot do anything, try to feed them. They might eat a lot, but they're essentially, um, uh, there's so many things that going on with this thing. In this general is known as cachexia. Okay, so how do we assess this neoplasm? What are some of the ways that we can study it? You can certainly look at the cells and the tissue. By the way, this will be considered anatomical pathology. So neoplasm is very anatomical. We can look at the behavior of the cancer. So again, um, uh, I'm trying to distinguish the difference between um, um, grading versus staging. Okay, so staging is we're describing the behavior, whereas grading we're just describing the anatomy. Okay, is the lesion, so in grading we're looking at the lesion themselves and see, is it bloody, right? Is the stromal cell still there? Is hyperchromatic, the cell staining? Are there any mitotic cells there? You might want to stain to see is there angiogenesis there. Maybe there is, maybe there isn't. But typically, large tumor, you see necrotic center, or sometimes there's bloody in the center, right? So that's all you get the gist, right? Grading. Whereas staging is really based on TNM for how big is their size. Okay, this is very important, okay? Uh, and it's very important to know the tumor size for several reasons. One is, if it's the tumor is getting bigger, or on the opposite is, okay, if you give some kind of treatment, right, is the tumor getting smaller, right? So if his tumor is regressing, then mean, oh, the person is responding to this chemical treatment. If it's not, then you're taking all this, it's not doing anything. Tumor just doesn't change. In here is for node. Is the node positive or not? If it's node positive, it's usually considered stage 2, for example. And M here for metastatic. Do you find the tumor in the lung? Do you find the tumor in the liver? Do you find the tumor in the bone marrow, for example? If it is, that's usually stage 4 cancer. And stage 4, not good prognosis than stage 1, for example. All right, so neoplasm, anatomy, and behavior. So treatment, it depends on grading and staging. I kind of tell you the difference between what is grading and what is staging. Grading is anatomical, staging is physiological, be clinical, if you will. The question is, what is the single important factor in determining prognosis of the therapy? It is the size of the tumor, okay? So is the size getting smaller? That's good prognosis in terms of therapy. If the size getting bigger, even after radiation treatment, then I'm sorry, but you know, maybe you have to make a will soon. Mm. Other considerations consider node and metastatic site. All right, so another way is that you can also study the cells, and for the diagnosis, there's different ways that we can look at to study. One, of course, is you remove the piece of tissue. Everybody knows that is biopsy, right? But more importantly, if you take the tissue, right, on the slide, can we look for the presence of epichem, for example? If that's the case, you do what we consider as immunohistochemistry. And immunohistochemistry is using the antibody. So let's say that this thing do express epichem, right, to find out whether it is, um, you know, epithelial origin or not. You would add an antibody. Okay. It doesn't proportional, but the antibody is bind specific to epichem, and you can usually label this antibody. And so an antibody does is that it allows you to, antibody is very specific to the antigen, in this case epichem. And so wherever that epichem is, that's where you find the antibody. If you label the with something, a fluorochrome or something, or perhaps an enzyme, and then you add a substrate to this, and then it give you now a brown color if the enzyme is present. Okay. The substrate. Then it gives you a product, and the product is usually brown color, a product. And you can look up, the paper that I published in on the cover of Journal Experimental Medicine. You can see we did the staining, looking for a brown color. Then, you can also look for presence of VEGF. If VEGF is a lot, then suggested angiogenesis is around. So that's what's known as immunohistochemistry. So immunohistochemistry uses the antibody, and you don't want to know more about this procedure, just write down the name in YouTube, and that will give you an idea how to do immunohistochemistry. Fine needle aspiration is basically, again, instead of removing the lesion, like very invasive, right? Like removing the lymph node to see if there's no positive. That's a biopsy. Sometimes you can just go in with a needle and remove some of the cells from that primary site, called fine needle aspiration. Cytology is you wanted to examine the individual cells. So this is very common in looking for blood cancer cells, for example. Okay. And basically, it's the study of the cell to see if the cells may have something else is produced in the cytoplasm. Okay. That's known as cytology. Another thing what blood cancer cells do is they often use what we call it flow cytometry. And what flow cytometry is also relies on antibody, but this antibody now is tagged with fluorochrome. Okay. And a fluorochrome is just a like FITCs or something. It's just a protein that if you excite it with certain wavelength, it emits certain wavelengths so you can see. And so basically what you do is that if this antibody is bind to, say, CD4 positive T cells, okay, and there's a machine, we call it FACS, for fluorescent activated cell sorter. And what this thing does is that it has a tube, and this tube sucks in these sample that have these cells and the antibody. Okay, and essentially what it's going to do is you're going to get single files of cell going through, and you're going to shine the light, okay, a laser, for example. If this one has an antibody sticks to it, it will emit out, right, the emission. Well, in other words, the cell will fluoresce. Okay, so fluoresce, cell fluoresce, and then essentially what you're going to do is you're going to look at how many numbers of fluorescent cells. Right, if a normal blood may have, say, 5% of the cells fluoresce in a normal person. In the case of cancer, for example, you may have 10-20% of the cell CD4 positive. Or in CMV, which I talked to you earlier, chronic myelogenous leukemia, in which there's a translocations of chromosome 9 to chromosome 20, activated the tyrosine kinase pathway. There might be an increased numbers of neutrophils, for example. And so that's how you can, another way to look for cancer is to this flow cytometry. Okay? Cytology is study of cells, or you can look at any cells, blood cells, or in the case of people do pap smear, see whether the cells are changing. If the lesion look abnormal, if you start seeing a lot of immune cells associate with your cells that you scrape from the cervix. If there's not a lot of immune cells, it's okay, but there's a lot of immune cells and suggesting there's something there. There are some markers that don't work too well, but we can see them. So the one exam question might be, okay, if you saw CEA, okay, CEA stands for carcinogen embryonic antigen. This is the antigen that usually expressed very early in human development. So differentiated cells, you do not see them, but some cancer cell, they start to express them. And so if they're high CEA, they're on a lot on the blood and on tumor cells. Let's say that hepatocellular carcinoma, liver disease, you might see them as well. So high CEA suggested that the person may have cancer. Not all of them, because there are some people who have cancer, but their CEA is absent, for example. Another one is alpha fetoprotein. Again, one of these protein expresses very early on, but it's not not in all cases. But the problem with these is that it is a good indicator for a hepatocellular carcinoma, right? But in some people, it might have false positive. In other words, you see a high AFP, but they do not have hepatocellular carcinoma. Okay. In this case, it's particularly children, high AFP suggested that could be a neurological, neural tubal defect, if you will. Okay. So it's not very specific to hepatocellular carcinoma. Likewise, PSA, we talked about earlier how around 70, the development of PSA is, suggests that someone has prostate cancer, but not always, and because it's detecting is controversial, because some people may have high PSA and they may have benign prostatic hyperplasia that does not necessarily cancer yet. It's just benign stage. And so this would consider as false positive, because high PSA, you think that someone has prostatic cancer, but it's not. So it will be considered as false positive. Okay. Pap smears, cytology, if you will. You look at the individual cells. This is kind of like weird. Right? Normal cells will look like this, but look at the darker stainness nucleus. There are some immune cells, not too much. And more bloody, so the red blood cells here. So it's bleeding. Okay, so this would be cytology would do this. Um, Gross anatomy neoplasm, again, so this would be considered as grading. In grading, now this is say benign versus malignant, and how you can tell between benign and malignant. Benign will still have stroma or basement membrane surrounding it. Here it's not. It's lost that. Typically, it has no capsule. Okay, so in other words, if there's a stroma, we call it a capsule. Um, and if in the case of the breast cancer, and you see they describe them as stellite, okay, stellite, a starlight. Then that means it has this radiation pattern, if you will. Okay, radiation, and particularly if this lesion attaches to the skin, that's very worrisome. Okay, that's very worrisome. So metastatic site, malignant cells, for example, do not have capsule. Okay, if it's a more epithelial, it's invasion to the lymphatic. But if it's glandular, and glandular could go into the blood, but typically blood metastatic through the blood is are cells from mesenchymal or sarcoma type of lesion. Um, there, the another important thing is that by differentiated cell, you can say that they're kind of like um, they look the same. Okay, they're round, for example. If they're undifferentiated cells, they lose just the shape. You know, they don't have to be round like that. Okay, they be like that. So we call that asymmetric uh, shape. Necrosis, dead center, because probably not a lot of angiogenesis um, and more development. Hemorrhage in the blood. So all of this characteristic is defined as grading. You're grading the tumor. And you can give it grade 1, grade 2, grade 3, or 3, 4, depends on the tumor. Just comparison between benign versus malignant. Benign growth is slow, malignant is rapid. Invasive benign, no. Malignant, yes. Metastatic benign, no. Malignant, yes. Contours, usually round, smooth, stellite. Okay, that's a good word to know. Irregular. Capsule is usually present in benign, absence in malignant. Necrosis, absence in benign but present. Hemorrhage, absence of benign but malignant. You see it. Organization resemble the normal tissue, right? So they're differentiated. Here they do not resemble, so they're undifferentiated, if you will, right? So the malignant is hard to treat. Cells again resemble normal, not resemble. Again, nuclei, abnormal size and color too, not just shape. And there are a lot more metastatic cells in malignant versus benign. Here, as you can see, these are very definitive normal cells, if you will, differentiated. Over here, it's kind of hard to see whether they're differentiated or not. And they're well differentiated or not in mitotic cells. You can see here. Um, there might be this one, maybe mitotic cells. You look at the DNA that is lining up, for example, that is mitotic cells. Then that means they're rapidly dividing. normal architecture, uh, cells and nuclei darker staining. That's very present here. This looks like it's dividing cells, mitotic cells. All right, so grading versus staging, grading, pathological exercise, like anatomical. Okay. Staging is clinical. Grading, you can say grade 1, grade 2, grade 3. You probably don't need to know different grading, but just remember grading, you define them whether differentiated or not, the cells, the architecture, right? Whereas staging is rely on three things: tumor size, necrosis, whether the tumor is present in the node, and metastatic, whether there's tumor cells are in the metastatic site. Um, okay, let's finish up this. I just have a couple more. Um, Grading and staging. Grading is a way classifies cancer cells. Pathologists cancer grade based on how different they look from normal cell differentiation, how quickly they are growing and dividing, are they neoplastic cells, and how likely they are uh, likely to spread. Staging, keep in mind that staging will based on tumor size, node involvement, and metastatic size. Okay. All right, so here will be the last slide. Actually, a couple more slides. All right, the how do we treat certain of the cancers? Um, if you catch it early, you can say breast cancer, and it's node negative. You can certainly have surgery to remove it. Uh, you just remove that one area, lumpectomy, but you want to be on the safe side. You can remove the whole breast, for example, mastectomy. Depends on the type of cancer, but certainly you can do radiation, and we can do local, and sometimes that's very effective. You just target that one area. Chemotherapies, numbers of drugs. The problem with these chemo agents is that they have a lot of side effect. There's no magic bullet to only treating your cancer cells. They target all kinds of cells. It's just a side effect. Um, and then recently, there are other kinds of cancer that we have reached a point where we can call it customized medicine. We can look in the breast cancer, we can see certain pathway that is activated. And one woman versus another woman is different. Before it's all breast cancers the same. No, now it's not. It's not because we can target certain signaling pathway that is common in this person but not in the other person, and then so target the treatment toward. I hate to admit it, but rich people can do that. They go to Sloan Kettering and they get better treatment than you go to SUNY Downstate, something like that. Okay, it happens. It does that. Um, that's what we're talking about. Health disparity. You're rich, it seems like better treatment than if you're poor. It's unfortunate, but that's what happened. Please know. Um, um, uh, these four different types of drug. Okay, um, so Gleevec is an a drugs that targets enzyme that is upregulated in chronic myelogenous leukemia. Okay, like CMV, for example. So people with CMV, Philadelphia chromosome translocations of 20, um, chromosome 9 to chromosome 20, that is Gleevec. There, um, I understand from my wife that people on Gleevec they bounce back. They quickly develop resistance. Originally, they said, oh, people respond really well with Gleevec. Um, Herceptin is a company that developed antibody toward EGF or epidermal growth factor, right? So we call HER receptor in general. HER is for human epidermal growth factor. Right? So Herceptin is targeting this. So in other words, it blocks the effect of EGF. So if the breast cancer require epidermal growth factor to grow, well, this antibodies is blocking the effect, thus deprives the cancer cells of epidermal growth factor. Unless now they become HER negative, then how do you treat them? Okay. Well, does it have estrogen, ER positive? If it's ER positive, it's easier to treat because you can treat them with tamoxifen, which is similar to estrogen. But if they're ER negative, so what do? Okay, you try RE486, maybe progesterone analog, but what if they're progesterone analog negative? The other thing with RU486 is that you got to be careful because RU486 is anti-abortion pill. It can causes the shedding of the endometrium. Oh, Avastin, I think I said aplastin. I think I meant Avastin. Okay. Avastin is a drugs that is targeting VEGF, epidermal growth factor. It's actually targeting angiogenesis. So it's Avastin, not aplastin. Okay. What are cancer treatment? You can just read these. If you want to read about James Allister's work on immunotherapy, that will be good too. James Allison, good. Okay. How he's using cytotoxic T cells. And then lastly, what are early detections for preventing cancer? Not all of them work. And we can see that PSA tend to have false positive for pancreatic cancer. Pap smear does help to see cytology in terms of early having cervical carcinoma or not. Of course, you can also vaccinate daughters or young teenager for human papillomavirus because HPV is often associated with cervical carcinoma. Mammograms certainly help, but again, mammogram is to look for the lesion only if you suspect it, and if you're don't I wouldn't recommend that if you do like under 50 if you will, because that's you exposing your breast to radiation and prolong. We always have to worry, what is the risk versus the benefit, right? If you're exposing your body to radiation to see whether you have breast cancer or not, and you're normal, so why do you increase that risk, right? So you don't do it. But it does help because if in the case of breast cancer, early detection is very treatable, but late, stage 3, stage 4, hard, very hard. And, breast cancer death in women, top 3. And colonoscopy in like me, over 55 is recommended. And you see those polyps and mini polyps and biopsy the polyps to see whether, I'm predisposed to have colorectal cancer. If you have many polyps, you might have to do again in the next 5 years, but not a lot, 1 or 2. You can wait till 10 years. All right, I'm going to stop here.